Good morning, everyone. What today we are going to discuss is the renin-angiotensin system, that is also known as, in the short form, it is RAAS. But we will discuss this in some other way by seeing the case scenario based. So first we will see the case, then we will try to solve the these questions related to the case. So one is this is a case, a 65-year-old male जो diagnosed हुआ with the congestive heart failure, and because of this congestive heart failure he was having the pitting edema, dyspnea and cough on mild exertion, angor's neck pain. So these are the symptoms of CHF and mild cardiac dilatation. The pulse was 100 per minute, respiration 20 per minute, BP 130 by 86 mm of Hg. So BP was okay, and what he was prescribed, tablet furosemide he was prescribed. Furosemide 40 mg tablet was prescribed for the CHF part. Captopril is another ACE inhibitor. We will discuss this. He was prescribed twice daily. Captopril 25 mg. After giving these drugs, after 2 hours of medicine, he complained of increased quantity of urine. So he was complaining of increased quantity of urine, and in the next few hours, his BP was decreased. The pulse was recorded 110 per minute and BP was 80 by 40 mHg. Initially the BP was okay, but later on, after these two drugs, the BP was decreased. So we have to see the patient was of the congestive heart failure, and the two tablets were prescribed, tablet furosemide and captopril. These two tablets were prescribed. Captopril is a ACE inhibitor, furosemide is a diuretic. And these, after the prescription of these two, the patient complained of increased quantity of urine, and patient also complained some dizziness and fainting attack because of the blood pressure was noted. It was reduced 80 to 80 by 40 mmHg. So what could be the cause of sudden onset of symptom? Sudden onset of symptom in the form of increased quantity of urine and is decreased BP. What will be the cause of this? And we will see why, how can we treat this or how can we overcome this shortcoming while giving the prescription of these type of patients. So come, let's see the graph which is important for the renin-angiotensin system. We have to understand first of all the physiology of renin-angiotensin system. First of all, there is an angiotensinogen. This angiotensinogen is converted into angiotensin 1 with the help of renin. So renin is produced where? In the juxtaglomerular cells of the kidney. So renin is produced in the JG cells of the kidney. So this is the JG cells which are present in the kidney. JG cells present in the kidney. So renin is produced from here. Angiotensinogen get converted into angiotensin 1, and this angiotensin 1 will further convert into angiotensin 2. So these are the factors which lead to the increase in the response of renin. When there is a sodium chloride loss, renin will increase. When your BP will fall, then again the renin will increase. So when renin will increase, RAAS system will get activated, and your BP will come to the normal. Renal ischemia is there, then again the renin will increase. These are the conditions where there is increase in the renin level. Angiotensin 1 gets converted into angiotensin 2 with the help of ACE. This is very important enzyme. ACE is angiotensin converting enzyme. Angiotensin converting enzyme. This is the ACE. ACE is angiotensin converting enzyme, and this angiotensin converting enzyme is present in the lungs. So remember this ACE is present in the lungs. From the lungs it is coming to the kidney part. So angiotensin 2 is formed, and angiotensin 2 will lead to the formation after that angiotensin 3, and after that angiotensin 4, after that inactive peptide. So this is how the angiotensinogen RAAS system activated. The important part here is angiotensin 2. Angiotensin 2 can act on different receptor, angiotensin 1 receptor, angiotensin 2 receptors. So angiotensin 2 is acting on angiotensin 1 or 2. Angiotensin 1, why I have written? Because it is important. Angiotensin 1 receptor mediates the vasoconstriction. When there is a vasoconstriction, there will increase the BP. We have the fall in the BP, the BP will increase. And angiotensin 1 receptor is responsible for left ventricular hypertrophy. Why it is important? Left ventricular hypertrophy means cardiac remodeling. Cardiac remodeling. So this is very favorite topic कि how to decrease the cardiac remodeling. What are the various drugs which can decrease the cardiac remodeling? So when we can decrease this one, so the LVH, left ventricular hypertrophy or cardiac remodeling can be decreased. Increase in aldosterone level is also there, and the increase in catecholamine. So this is the function of angiotensin 1 when angiotensin 2 act on angiotensin 1 receptor. There is a role of beta 1 also, because beta 1 will stimulate the formation of angiotensinogen, and this ACE is one important in one more thing. ACE will cause the bradykinin metabolism. So suppose we are giving the drug which is blocking the ACE, the bradykinin will increase. Bradykinin will increase, so side effect will be there. So one peculiar side effect with the ACE inhibitor will be seen. We will see that also. So because of the bradykinin. So what we can do, what are the drugs we have in the RAAS system? RAAS system is very important in hypertension point of view, heart failure point of view. So RAAS, where we can attack the RAAS system, we can give the beta 1 blocker. We have discussed the beta 1 blockers. We can decrease the activity of renin. This is the latest drug, renin, which is inhibiting the renin. We can decrease the activity of ACE, angiotensin converting enzyme, by giving the ACE inhibitors, and we can block this receptor, angiotensin 1 receptor blocker. We have the ARBs, angiotensin receptor blockers, and we have the aldosterone. So all these things, beta 1 blocker or renin blocker or ACE inhibitor or AT1 receptor, all these things will help in the decreasing the cardiac remodeling also. Why? Because they are inhibiting the formation of left ventricular hypertrophy. लेफ्ट वेंट्रिकुलर हाइपरट्रॉफी नहीं होगी तो रीमॉडलिंग नहीं होगी. Okay, so when we decrease the cardiac remodeling, we can increase the mortality also. So in that point of view, it is very important. Why I am so much focusing on left ventricular hypertrophy? It's a cardiac remodeling, because we can decrease the mortality. We have to avoid the hypertrophy. So ACE inhibitors, why I have made that lump? Because the ACE enzyme is coming from the lungs only. So in the ACE inhibitor, these are the drugs. So we have seen we are inhibiting the ACE enzyme. Then remember one thing also, ACE enzyme is also known as kinase 2, because this is this you may forget, but this is very important. ACE enzyme is also known as kinase 2, which help in the conversion of angiotensin 1 to angiotensin 2. First ACE inhibitor was this tiplotide, but this was not very effective. This is not used. This is not used orally. We don't have the oral form of this, so that's why it is not very much useful. Other ACE inhibitors जो सबसे पहले आई was the captopril. Captopril was the first orally effective ACE inhibitors. Captopril was the first orally effective. After this captopril, another or prils आई. So ACE inhibitors, all the ACE inhibitors name end with the prils. All the ACE inhibitors name end with the prils. So first was the captopril. Additionally, they inhibit the breakdown of. We have seen in the diagram that ACE enzyme is responsible for the bradykinin metabolism. अगर inhibit कर दिए ACE enzyme, they will be increasing the level of bradykinin, and bradykinin will accumulate, will lead to the specific side effect. Okay. So these are the various ACE inhibitors we have in the market: captopril, lisinopril, enalapril, perindopril, ramipril, tenofovir, benzapril, quinapril, moxapril, fosinopril. Captopril is the prototype, was the first oral ACE inhibitor. Then other ACE inhibitors have been derived. And the important thing that you have to remember here, these are all the prodrugs except two drugs. We remember here with the CL. Except two drugs, rest all other are the prodrug, and CL is the captopril and the lisinopril. Captopril and the lisinopril are the not the prodrug, they are the active drug. Active drug means their action will be more intense. If there is active drug, ये प्रोड्रग है, इनका एक्शन धीरे धीरे आएगा, कैप्टोप्रिल का एक्शन तेजी से आएगा. So that is the reason we have to remember this one, because this is related to that question जो अभी केस बेस्ड सिनेरियो था. This is related to this, क्योंकि कैप्टोप्रिल वहाँ पे पूछा गया. So एक और ड्रग है एनालाप्रिल, एक प्रोड्रग है. एनालाप्रिल is get convert into enalaprelate. So this is another 1, 2 and 3. So this is also an active drug, enalaprilate. Enalapril is not an active drug, enalaprilate is active drug. So we have the 3 exceptions, not the 2: captopril, lisinopril and enalaprilate. Okay. So now come to the therapeutic use, where we can use ACE inhibitors. It is decreasing where the angiotensin 1 is causing the vasoconstriction, so it is inhibiting the vasoconstriction, so we can use in the hypertension. ACE inhibitors finally will reduce both the systolic and in fact, in the hypertension guideline now you have the A, B, C, D. These are the drugs. B have been removed from the guideline. Now B is no more the drug of choice or the first line drugs. Only A, C and D. Where A is the ACE inhibitors or ARBs, C is the calcium channel blocker and D is the diuretics. So these are the first line drug, ACE inhibitors and ARBs. But ARBs is blocking the final step. So that's why ARBs are more popular than ACE inhibitors. Because अगर ACE inhibitors we are blocking, so there are non-ACE pathways also, which will lead to the formation of angiotensin 2. So in ARBs, no, this is the final step. Like in PPI, we have the final step as proton pump. In here also, the final step is angiotensin 2 action on AT1 receptor. So given either as a monotherapy or in combination therapy with diuretic, ACE inhibitor is available with diuretic also or beta blocker also. Antihypertensive effect gradually develop करता है with ACE inhibitor. लेकिन अगर हम कैप्टोप्रिल की बात करेंगे, उसका जल्दी develop करेगा because it's not a prodrug, which is more pronounced, there is high. So antihypertensive effect gradually develops over 2 to 3 weeks with the ACE inhibitors. In the heart failure also, there is a role of ACE inhibitors because it is reducing the preload and the afterload both. How it is reducing the preload? It is reducing the left ventricular filling pressure. And how it is reducing the afterload? Because it is vasodilatation. It is causing the vasodilatation, so that's why afterload is also reduced. So the thing is, ACE inhibitors and ARBs both is helpful in preventing the cardiac remodeling. So it may also reverse the ventricular remodeling by inhibiting the formation of angiotensin 2. Angiotensin 2 was causing the left ventricular hypertrophy, that is the cardiac remodeling. So here we are discussing this. In the myocardial infarction also, it will prevent the remodeling part. So after myocardial infarction there will be more infarction के chances नहीं होंगे, recurrent MI के chances कम हो जाएंगे. The long term treatment for up to 6 months can reduce the mortality, but it is contraindicated in hypotensive and cardiogenic shock. And the diabetic nephropathy is the thing which is very important. Diabetic nephropathy, अगर hypertensive patient है along with diabetes, the preferred drug is ACE inhibitors or ARBs. Because this can be helpful in both hypertensive and normotensive diabetic retinopathy, because it is decreasing the microalbuminuria part. It will prevent the renal damage also, because it is acting on the RAAS system. It can prevent the microalbuminuria also. So ACE inhibitors are the drug of choice when there is a diabetic nephropathy also. In plain diabetic nephropathy without hypertension also ACE inhibitors are given. In diabetic nephropathy with hypertension also ACE inhibitors are recommended. So it is superior to calcium channel blocker, beta blocker. This is very important question. Many times it has been asked that if the patient is, the case scenario is like this, diabetic nephropathy, patient is diabetic nephropathy and hypertensive also, what is the preferred treatment? So ACE inhibitors will be the preferred. It is more superior than calcium channel blocker, beta blocker and thiazide diuretic. So remember this part. Scleroderma crisis also, there is an improvement by inhibiting the formation of angiotensin 2 against it will inhibit the vasoconstriction part. ACE inhibitors, the pharmacokinetic more or less we have discussed, all are the prodrugs except two drug was there, captopril and lisinopril, and the third drug enalaprilate. Enalaprilate is active form of enalapril. So captopril, lisinopril, enalaprilate. Duration of action is 24 hours, लेकिन captopril active drug है ना, captopril active drug है, इसको twice a day. In the case based scenario what we have seen in the first slide, in that also the BD dose was given. Okay. All are eliminated by the kidney. तो किडनी से एलिमिनेशन है एक्सेप्ट फॉसिनोपिल. If there is a renal impairment, then also ACE inhibitors can be given, but the ACE inhibitor which can be given is the fosinopril and spironolactone. Adverse effect is very important, so we can remember this adverse effect in the mnemonic of captopril. Captopril is there. Cough is because of the bradykinin. Cough is because of the increase in the bradykinin. There was increase in the bradykinin, so dry and brassy cough is there. A is angioneuritic edema, P is proteinuria, T is teratogenic. ACE inhibitors are teratogenic in the second and third trimester. This you have to remember. Not in the first trimester, second and third trimester. These are the teratogenic. And orthostatic hypotension, because it is decreasing the BP, and maximum orthostatic hypotension is seen with the captopril. Please remember this one. But we have seen that captopril is an active drug, तो वो जल्दी एक्शन करेगा और बीपी कम भी कर सकता है ज़्यादा, तो ऑर्थोस्टैटिक हाइपोटेंशन. ओके, दिस कैप्टोप्रिल वाज देयर इन द केस सिनेरियो. आर रैशेस मोर कॉमन विद द कैप्टोप्रिल एंड एस इनहिबिटर्स. अब नीचे जब जाएंगे तो पोटेशियम भी इनका एक साइड इफेक्ट है. एस इनहिबिटर्स और एआरबी दोनों के ही हैं. दे विल इंक्रीज द लेवल ऑफ पोटेशियम, सो इट इज कॉन्ट्राइंडिकेटेड इन पोटेशियम स्पेरिंग डायबिटिक, एंड एल इज फॉर लॉस ऑफ टेस्ट डिस्गुजिया. So ACE inhibitors are preferred along with diabetes mellitus. ACE inhibitors are preferred अगर hypertension के साथ diabetes है, hypertension के साथ ischemic heart disease हो, VLF ventricular hypertrophy, then also ACE inhibitors are preferred. Okay? ARBs angiotensin 1 receptor को ब्लॉक करते हैं, ACE को ब्लॉक नहीं करते हैं. So जो ACE inhibitor की वजह से bradykinin जो बढ़ रहा था, उस पे इसका adverse effect नहीं आएगा. मतलब dry cough ARBs से we will not see. और this you have to remember कि ARB is acting on 81 receptor, not 82. 81 only. This is also an important question. Acting on 81 receptor only, not the 82. Okay. The ARBs की affinity है for the these are the various ARBs what we have available, and ARBs like ACE inhibitor and with pills, ARBs and with the sartan. ARBs, all the ARBs and with the sartan. सबसे maximum affinity is with the candy sartan and lowest affinity is with the losartan. Maximum affinity with the candy sartan and lowest affinity with the losartan. तो ARBs की एक एंटीप्लेटलेट एक्टिविटी भी होती है. इर्बिसार्टन इज द एंटीप्लेटलेट. इर्बिसार्टन की मैक्सिमम एंटीप्लेटलेट एक्टिविटी होती है. तो इर्बिसार्टन कैन आल्सो बी यूज्ड इन द प्लेटलेट एग्रीगेशन, जहां एंटीप्लेटलेट एजेंट्स यूज करते हैं वहां पे बिकॉज ऑफ ब्लॉकेट ऑफ थ्रोम्बोक्सिन A2. इर्बिसार्टन लेकिन एक जगह और यूज होता है, एंटी एरिथमिक. इर्बिसार्टन कैन आल्सो बी यूज्ड एज एंटी एरिथमिक. दिस इज इंपॉर्टेंट. नाउ यू हैव टू रिमेंबर दिस, क्योंकि इसमें इंपॉर्टेंस ये है कि वी आर डिस्कसिंग ARB, लेकिन ये ARB ऐसी हैं जिनकी एक्टिविटी PPR गामा इज प्रेजेंट इन डायबिटीज में था. तो जिनकी एक्टिविटी PPR गामा को भी ब्लॉक करने की होती है. तो अगर हम पूछेंगे टेल मी द ARBs, तो यू हैव टू रिमेंबर telmisartan. Telmisartan इज द ओनली ARB व्हिच हैव एक्टिविटी अगेंस्ट PPR गामा. PPR गामा कौन से थे डायबिटीज में? ग्लिटाजोन्स थे, पायोग्लिटाजोन, रोसिग्लिटाजोन, वो सब थे. तो PPR गामा को भी ब्लॉक करता है, thus helpful in the controlling the hyperglycemia also. तो if अगर we are discussing both diabetes भी है, hypertension भी है, then which one is the best drug? This telmisartan is the best drug. But tell me अगर पूछे तो telmisartan is the only drug which is inhibiting the PPR gamma also. And कौन सी जिसकी वीक एंटीप्लेटलेट एक्टिविटी होती है? इर्बिसार्टन की एंटीप्लेटलेट एक्टिविटी भी होती है. शॉर्टेस्ट एक्टिंग इज द इप्रोसार्टन इज द शॉर्टेस्ट, एंड losartan longest acting होता है. iprosaartan is the shortest acting and increase the cognitive function. This role is not have been illustrated yet very much, but iprosaartan has found to be role in increased cognitive function. What are the differences between ACE inhibitors and ARBs? So first of all, ARBs were not blocking this enzyme, not inhibiting the metabolism of bradykinin. Bradykinin मेटाबोलाइज होगा तो ड्राई कफ ये सब सिम्टम्स नहीं आएंगे जो ACE इनहिबिटर से आ रहे थे. द सेकंड, ACE इनहिबिटर्स 81 रिसेप्टर को ब्लॉक नहीं करता. एंजियोटेंसिन 2 can be formed from the non-ACE pathway also. I told you कि ACE pathway तो है ही, non-ACE pathway से भी angiotensin 2 बन सकता है. The third ACE inhibitors दोनों को ब्लॉक करता है 81 और 82 और ARBs only 81. You have to write, remember, angiotensin 1 receptor. So therapeutic use is more or less similar in hypertension. Hypertension में फर्स्ट लाइन ड्रग है ACE inhibitors और ARBs. हार्ट फेलियर्स में ये एक इंपॉर्टेंट अर्नी आया है. व्हाट इज अर्नी? अर्नी इज एंजियोटेंसिन रिसेप्टर. AR इज एंजियोटेंसिन रिसेप्टर ब्लॉकर और NI इज नेप्रिलाइसिन इनहिबिटर. Angiotensin receptor blocker is the Saturn, valsartan, और neprilysin inhibitor is the sacubitril. तो दोनों का कॉम्बिनेशन ऑफ ड्रग अवेलेबल है अर्नी, जबकि CHF में नई ड्रग है ये अर्नी. valsartan और sacubitril का कॉम्बिनेशन है. angiotensin receptor blocker valsartan और sacubitril is a neprilysin inhibitor. ठीक है? What is the role of neprilysin? We will see in the CHF, in the heart failure part. But you have to remember the अर्नी because we are discussing the sartans, we are discussing the ARBs. Okay. The third is acute MI. In acute are equally effective. It will prevent the further recurrent MI and diabetic nephropathy recommended. अगर diabetic nephropathy तो ACE inhibitors और ARBs are always recommended. Stroke prophylaxis में portal hypertension में losartan is recommended. Dysarrhythmia का रोल irbesartan का है. Irbesartan also acting as a antiarrhythmic agent also. तो ARBs का एडवर्स इफेक्ट बस कफ नहीं होगा, बाकी सिमिलर टू कफ एंजियोडेमा नहीं होगा, बाकी रेस्ट आर सिमिलर टू व्हाट वी हैव डिस्कस्ड विद दैट कैप्टोप्रिल. एक करके कैप्टोप्रिल था जो निमोनिक एंड हाइपोटेंशन में अकर बट नॉट द फर्स्ट डोज हाइपोटेंशन. तो फर्स्ट डोज हाइपोटेंशन इज नेवर सीन विद द ARBs. इट इज जनरली सीन विद द ACE inhibitor that too maximum with the captopril. As it is an active drug. This is the new drug renin inhibitor which is known as eliskerin. Renin inhibitor inhibiting the renin. Oral form is available. Competitively block the renin receptor. Antihypertensive effect nearly equal to ACE inhibitors or ARBs, and it also reduces the left ventricular hypertrophy. So again, because it is inhibiting the renin, which will finally inhibit the formation of angiotensin 2. So also reduces left ventricular hypertrophy, and that will be beneficial in mortality, also reducing the mortality. Have renoprotective effect also. Given orally, but it has having the very low oral bioavailability. So this drug, this eliskerin is a substrate for the P-glycoprotein efflux pump. It is get effluxed by the P-glycoprotein pump. So that's why its oral bioavailability इसकी बहुत कम होती है. Mainly limited in the feces. Half life greater than 24 hours. Adverse effect is very less, mild, mainly dyspepsia, headache, loose motion pain, abdominal pain. Not very much adverse effect is seen with this eliskerin. But the first line drug are again the ACE inhibitors and ARBs, not this one. So coming to back our case based. So our case was this, in which the patient was having the CHF and was prescribed this furosemide and captopril. Now you know the captopril. Captopril is the first ACE inhibitor, is the prodrug. It's not a prodrug. Captopril is not a prodrug. It's an active drug. Active drug was captopril and lisinopril and enalapril. So the doctor has given captopril and furosemide. What captopril was doing? Inhibiting the ACE, leading to inhibition of formation of angiotensin 2. Angiotensin 2 तो फिर उसका BP जो है वो अल्टीमेटली सोडियम और वाटर रिटेंशन और वैसोकंस्ट्रिक्शन हो जाता, तो दैट्स व्हाई उसका बीपी कम हो गया. तो ये दिया गया था. एंड इंक्रीज क्वांटिटी ऑफ यूरिन बिकॉज ऑफ दिस furosemide, बिकॉज इट इज अ डाययूरेटिक, स्ट्रॉन्ग डाययूरेटिक, इट्स अ स्ट्रॉन्ग डाययूरेटिक, लूप डाययूरेटिक, इट्स अ स्ट्रॉन्ग डाययूरेटिक, हाई सीलिंग डाययूरेटिक. तो furosemide से इंक्रीज क्वांटिटी ऑफ यूरिन एंड कैप्टोप्रिल से जो है उसका बीपी कम हुआ. दैट्स व्हाई ही गॉट फेंटेड व्हाइल वॉकिंग टू द टॉयलेट. कैप्टोप्रिल वाज एन एक्टिव ड्रग. तो घर पर क्या किया, कैप्टोप्रिल ट्वाइस अ डे स्टार्ट कर दिया पेशेंट को. तो फिर वी कैन व्हाट तो what could be the cause of sudden onset of? तो कैप्टोप्रिल causes marked fall in BP और कैप्टोप्रिल को साथ देने वाला कौन कर दिया? Furosemide. Furosemide will also decrease BP, है? Sodium loss करेगा. Captopril will also decreasing the BP. So what we can do here, we can give the patient the lower dose of captopril. We can give the lower dose या फिर ऐसी ACE inhibitors दीजिए जो कि that is slower acting, धीरे धीरे काम करे ताकि hemodynamic adjustment हो पाए. So we can prefer the another ACE inhibitors. We have the other ACE inhibitors also. Okay. So these are the things what we can handle if we know the pharmacokinetics and if we know the pharmacology part. So that's why it's very important to know the pharmacology of the drug to prevent the adverse effect by the drugs. So thank you.